Good evening. Welcome to everyone to this three-part Podinar series and to the second Podinar. My name is Shannon Brothers. I'm a paediatric gastroenterologist at the Starship Children's Hospital in Auckland, New Zealand. This evening's session is on what is gut dysbiosis and is it the missing link. I have the great pleasure of being able to co-host this session with Rupert, Dr. Rupert Hines, consultant gastroenterologist at Monash Children's Hospital, and also to have two fantastic guest speakers, Professor Nikhil Thapar, who is Director of Gastroenterology, Hepatology and Liver Transplant at Queensland Children's Hospital, and also Professor Patricia Conway, who is currently displaced due to COVID in Queensland, but Professor at the University of New South Wales, with research interests in gastroenterology, gastrointestinal microbiology, with particular emphasis on bacterial colonization and function within the gastrointestinal tract. So a fantastic person to have as a guest speaker for this particular Podinar. So COVID has displaced some of us. For us in Auckland, we have now moved to being able to do picnics as part of our coming out of lockdown slowly and hopefully having most of our population vaccinated shortly. And I'm sure it has affected a number of people. So thank you very much for attending tonight's session, and we're looking forward to some interesting discussion. So I would encourage you to post as many questions as possible. We'd love to make this really interactive. We're happy to do a lot of talking, but actually we'd love to hear your questions and to hear from you throughout the discussion. And I'm going to kick off by doing a brief case study, and then might contrast that if we have time with another much briefer case study. And we'll try and make the case study as interactive as possible, and together with my co-chair and guest speakers, as well as hopefully take as many of your questions as possible. All right, so if you have any technical issues, please let the team at Nutricia know as we're moving through the evening. And otherwise, I will start with the presentation. So this is me. My disclosures are pretty much the only disclosures that I have is the honorarium for this talk, which I have donated to our Paediatric Society of New Zealand's Allergy Special Interest Group. I'd like to kick off by going, so what exactly is gut dysbiosis, or more specifically, what is gut eubiosis? I have a very limited understanding of this as a paediatric allergist. I'm going to ask my co-chair and our guest speakers to give us their take on this as well before I move on to the case study, just to set the scene. So from my take, which is a limited allergy perspective, changes in our living environment, diet, lifestyle associated with a very urbanized environment have led to altered microbial diversity, or even limited microbial diversity, disrupting disrupting the immune regulatory function of the microbiome and predisposing to allergic sensitization. And that gut microbiome composition and function is set up related to multiple environmental factors that babies are exposed to through the first 100 to 1,000 days starting in intrauterine life. That factors promote gut eubiosis, protective factors, such that commensal good bacteria produce short-chain fatty acids, and improve gut barrier integrity, help promote tolerance to food allergens. I'm talking specifically from a food allergy perspective. And that with dysbiosis is a prevalence of pathogenic bacteria due to various factors, with a reduction in immunomodulatory factor production, increased gut barrier permeability, allowing allergens to cross that gut barrier. And then that's a risk factor for food allergy development. Now clearly that's a very limited view on what gut eubiosis and gut biosis is. So I'd love to ask Rupert, for starters, what it means to him as a pediatric gastroenterologist.
So I suppose the question goes beyond probably the infancy. I mean, I think we are interested in terms of the relationship between the gut immune system and the microbiota. We try to manipulate it in many situations, certainly the way we treat Crohn's disease using a specific polymeric diet. You know, we know that changes the microbiota diversity. We know that a whole host of things in our diet do that as well. I suppose I would say that, and I have a slide like this, if you look at the number of publications in the microbiota space, you know, it's literally exploded over the last 20 years. You know, these were rare publications 15, 20 years ago. You know, now they're all over the place. And I think that's partly because of people's interests, as you alluded to, in that, you know, can we make a difference early on? But also because of much of the technology that's available. You know, it used to be very hard to culture, you know, all the bacteria that came out in the stool, but now rapid sequencing using sort of 16 sRNA for bacteria that we already know about means that if you've got the machine, you can come out with lots of studies. So I think we've seen a plethora of studies, not all of them good, but I think certainly there's huge interest in the gastroenterology space, not just within allergy, but also within other GI inflammation, particularly inflammatory bowel disease. But I still think we're much at the infancy of our understanding between the relationship of these bacteria, the downstream inflammatory response. You know, is it the bacteria? Is it what they're producing? You know, does it have different effects in different parts of the gut? The answer is almost certainly yes. So I think it's a great space to be involved in, but it's perhaps not as simple as we think it is. So it's hugely important for us, but as yet it's an ocean really, and it's, you know, yeah, we probably know there's a couple of sharks in the ocean, but we don't know, you know, what's going on in the deep depths, and that probably has particular relevance in the gut, where we're not very good at finding out about anaerobic bacteria that, you know, live within our gut, because they're hard to culture and we don't know about them. So it's an exciting time, but we can't do much about it. With probably the single exception, the only sort of area where I think it's come into really standard practice for us is fecal transplant. I think fecal transplant for, obviously, thankfully, this is not such a common problem in children, but clostridial infections in elderly people, the immunosuppressed, can be really hard to get rid of, you know, with antibiotics. And I think it's fair to say that a standard of care for, you know, resistant C. diff would be fecal transplant in kids and adults alike. So that's probably an area where it really is absolutely the forefront, whereas fecal transplants for stuff like IBD, really, it's not clear. So I feel like we're literally like a man on a horse, you know, trying to get across America. You know, we're going to get there at some point, but we've got a long way to go.
That's really interesting and different perspective from what we see in allergy, and in fact, I think in allergy, particularly for young children and infants, we're even more in our infancy and our understanding. I think in gastroenterology, you're quite a bit further ahead than us.
I think you're much cleverer than us, I'm sure.
I don't know. Nikhil, gut eubiosis, dysbiosis, what's your take from a gastroenterology perspective?
Sure. I mean, I guess I probably have a really simplistic view on dysbiosis, and I think as time has gone on, it's been even more confusing. I mean, I just simply think about dysbiosis is when the mutual benefit of having bugs within your body, because I think the normal situation should be that it's a benefit to you and it's a benefit to them, and everybody lives happily together. And what I think about dysbiosis is then when that mutual benefit kind of ceases to exist anymore, and then you start to see kind of harmful effects to either the host or the microbiota themselves. So that's the way I look at it, and I think it's also context dependent. And I think my maybe strong view on this is that I think what is dysbiosis for one individual may not necessarily be dysbiosis for someone else, and I think that's been a particular challenge within the field. And I mean, it's so important. This species seems to be so important because my particular interest is neurogastroenterology, and we know that microbiota within the gut are so essential for the early development of the enteric nervous system, so the nervous system of the bowel. And of course we know, and I guess we're going to talk a little bit about the effects on immune development as well, which is really critical. And it's quite clear that it's not going to be the same for everyone. So it seems that either you have a genetic predisposition and you have a dysbiosis in that context, and those things together result in effect, whereas in other individuals, the same thing doesn't happen. But I guess I have a much more simplistic view than most.
That is super interesting, because I guess one of the things I grapple with is how does this make a difference at an individual level? Before I move on to the first case, Patricia, if I put that question to you, how does gut dysbiosis or eubiosis make sense at an individual level? How do you explain that to people?
Well, I think,
or does it make sense?
It does make sense, and I see it from a research scientist perspective in gut microbiology. So I know what's there and what's not, and Rupert was so spot on when he made the comment that we can now analyze with the latest techniques the microbes that are there and the metabolites that are being produced, and in many cases it's now linked to neurological and immunological outcomes. But the term dysbiosis it's an individual. It's not that this particular profile is a dysbiosis for everybody. I see it as a dysbiosis of one's own microbiome, because and sadly there's a lot of analysis of a microbiome profile, and I've been asked to do this, but I say, well, if I do it, how do I interpret it? All I can say is, okay, you've got elevated E. coli's or if Clostridia difficile. I basically see dysbiosis as a variation from your normal healthy status, and we know that there's sort of groupings of microbiome profiles, but it is very much individual. And it's also, we know that diet, stress, environmental conditions, exercise all impact on the microbiome. So if someone's traveling and in a very stressful situation, their microbiome is going to change. But whether that change is going to lead to disease, and I think the term dysbiosis conjures up that it's a negative impact such that you end up with a clinical outcome. And so I think it's a really loose term.
I think that's, can I say, Shannon, I think that's beautifully put, Patricia, because I think clinically, I don't know how much you get it as allergists, but I'm sure Nicola and I are familiar with sitting in rooms with a child with a variety of gastrointestinal symptoms, and we're presented with a 20-page document entirely cataloguing the gut flora of this child. And as you say, Patricia, it's about the moment in time. It's not, there's not a causal link between that and the symptoms, but the parents will have been told there is an imbalance, this is causative, what do you do? And I think, that's the sort of the myth that we've got to sort of break through, because, people literally come in as if, these are the 10 commandments handed down by God as a structure for moving forward. And we see it all the time. And it's very hard to then unpick it by saying, well, it does depend on lots of things, and that stool that you've shown me today may not be the same, when you've moved to live in India for 6 months, or, when you've introduced solids into the diet. But I don't think necessarily the manufacturers of these tests, of course, they're financially driven, are selling that message. They're saying, this is the answer, this is the holy grail of your child. And I think, unfortunately, there's a lot of it about, and some of our sort of colleagues in for want of a better word, the alternative space, certainly use a lot of this testing. And as you said, Fisher, with no ability whatsoever to interpret what it means, apart from, reading the comments, which are obviously irrelevant because they're not person specific. I don't know, do you get many of those, Nikhil?
Yeah, no, absolutely. Well, I was just going to look on my desk because I actually had one yesterday. But yeah, I mean, we do, and it does worry me because it's always, you've always got to be able to think about the clinical context of what's the question. But my worry is that, it's even drifted down to kind of intelligence, like, could it be interfering with my child's kind of intelligence, and I really worry we're going to end up in a situation where people are getting kind of transplants to try and improve their IQ. I'm sure that it happens somewhere, but yeah, so I mean it's a huge problem, and I think we really have to have very clear messaging and often spend a lot of time about trying to put it in context of what it is we're trying to do in the first place.
That's fascinating. As I said, I think you gastroenterologists are far more sophisticated than us, because I've yet to see a single one of those, or maybe they just haven't hit New Zealand, those detailed reports. I would like to never meet one. Okay, so I'm going to take us to the case study then, and thank you, Nikhil, Patricia, Rupert, for setting the scene so beautifully and in a much more sophisticated way than me about what gut eubiosis or disruption of that means to you. So moving on to the first case. So I think I've made this case sound a lot simpler than it actually is, and we might move away from the slide at some points just to digest some of the complexities that actually occurred along the way in the first 9 months of this child's presentation. So I've underlined what might be potential risk factors for allergy, for food allergy. So male should have been underlined as well, apologies, of Indian ethnicity but New Zealand born. So parents who had migrated to New Zealand, but this is a New Zealand born child. So that places him at potentially at an increased genetic risk. No siblings, so first child. No family history of ASP, but no pets. Do these things matter at an individual level? I don't know. Perinatal history, full-term birth, spontaneous delivery, good birth weight, no perinatal complications. So, Patricia, I guess that's why I am so interested in the take-home of to what extent did these factors, there's obviously some genetic risk there, but the factors like there are no siblings, there are no pets in the house, in terms of microbiome, to what extent do these things matter at an individual level for my patients?
They have a huge impact, because we know that the microbiome, it's effectively non-existent in the newborn, and it successively develops. And it's quite a low diversity. And by diversity, I mean the number of different types that are there while the infant is on breast milk or formula. And once they start being exposed to the environment and crawling on the floor, and they're acquiring many more microbes until adulthood, when it's by 2 years of age, it's quite complex. But the first microbes that are there are the colonizers that often stay for a longer time. So the microbes that the bub is exposed to first off are very important. For example, a C-section born baby is born into a very sterile environment, and the microbes that a C-section baby is exposed to are the hospital-acquired microbes. And it's known that they are often the gram-positive undesirables, the staphylococcus and things like that. Whereas a vaginally born baby is exposed to mum's vaginal microbes. And so they have very different populations at birth. The C-section baby often has more like mum's skin microbes, whereas the vaginally born baby has the vaginal and therefore becomes more like the gut microbiome. But in addition to those microbes, the exposures the baby is exposed to is where they get their microbes from. And we need those microbes because in utero, the immune system is downregulated in one arm of it. Otherwise, the fetus would be rejected. At birth, we need the other microbes that are there to trigger the immune system. But it's well documented that siblings, country lifestyle, pets contribute to the acquisition of those microbes in a positive way.
And it's really interesting, though, that so yes, this child has no siblings and no pets, and there you would think there's some genetic increased risk. That he was born by normal spontaneous delivery, vaginal delivery, and when I was looking for cases, so real life cases, this is a real life case, patient who had cow's milk allergy. Every single one of them that I trawled through over the last 3 months was born by spontaneous vaginal delivery, and I thought that was quite interesting. Most of them did have siblings. I have to confess, I'm usually asked about pets in a really young infant. I wouldn't normally, but so it just struck me when I was looking for example cases that it was actually quite hard to find that quintessential patient who had disruption of the gut microbiome early in life. What would you, I don't know, Rupert, do you tend to have exemplar cases that usually have quite a setup for disrupted gut microbiome?
I think there's a real mixture, to be honest. I think it goes without saying it's a statistics business, isn't it? But certainly, I mean, obviously, I don't know what the cesarean rates are in New Zealand, but they're pretty high in Australia. So, almost by definition, around 30 or 40% of babies are going to be cesarean anyway. So that's close to 1 in 2, isn't it? And I think obviously there's a fair amount of atopy in Australia, but some of the rates of food allergy, I think this is work from your allergy college at the Royal Children's. We've got very high rates of allergy as well. So we not uncommonly see a family history of atopy or food allergy, and probably, as the statistics are, about half of them, just under half, would be cesarean. But I agree, not every child conforms to the stereotype of those risk factors. It seems like everyone in Australia's got a dog as well, so I think the pet protection clearly is not as valid as some of the literature suggests.
Yeah, I should have put in a photo to do with pets. I've made myself gastroenterologist now. Our pediatric immunology team at Starship, we only have one team member now who doesn't have a dog. I should have put up a very cute photo of puppies.
Yes.
Yeah, but I think it also depends on the hygiene that's practiced in the home, because if mum is super fastidious with hygiene, it means the bub is not being exposed to microbes, and a lack of exposure to microbes has been shown to contribute to a poor development of the immune system.
Very good point. So this baby then went on to develop unusually recurrent perianal abscesses with persisting fistulae from day 20, did require recurrent antibiotics. So this really is my exemplar case for disrupted microbiome, and had an incision and drainage, had numerous was told that it would need further incision and drainage because he had these persisting fistulae, at which point the parents disappeared to India to try alternative treatments there because they really didn't like the sound of that. I hadn't met the baby at this point. But Nikhil, with a baby like that, is there anything worrying about this history from a gastroenterology perspective?
Yeah, so I mean, in fact, when even when with this single slide, it really kind of triggers immune dysregulation. So, that's the thing which it, immediately sits. When I was based in the UK, you know, immigrant families that developed inflammatory bowel disease often developed early aggressive inflammatory bowel disease. And we were seeing a lot of that where families had moved actually from families that had no past history of those sorts of issues. So the thing which really stood out to me would be that, in fact, I would be worried that this child might have something like an very early onset inflammatory bowel disease and significant immune dysregulation. And we get referred a number of children who have perianal abscesses that persist, and this child clearly had an immune workup to investigate that. So we're already seeing a consequence possibly of the dysbiosis in terms of a disordered immune development, I guess.
That's a really good point. Rupert, from a gastroenterology perspective, are there any investigations you would have wanted to do on this child if he does come back, I promise, if he hadn't, before he left the country?
Look, I suppose as this follows on from Nikhil's perspective, but certainly you've got sort of the very early onset IBD that obviously Nikhil's alluding to, but I'd certainly worry about chronic granulomatous disease with all these abscesses. And some of these kids have a sort of a non-specific colitis associated too, and sometimes that's their first symptom. So I think, I mean, we live in an era where, probably for you as well, that we think nothing of asking for whole exome sequencing, and it screens for everything. But I think it's useful to try and think through what you're asked, what question you're posing. And certainly I've seen, a few kids who've presented like this who've turned out to have, chronic granulomatous disease, and he is a boy. So some sort of neutrophil burst function type of test. If I could have one test, I'd probably do that. But look, I think, I'm presuming that isn't the story. Otherwise, it would lend us down a different pathway. But yeah, that would be the thing you'd want, I think. And look, otherwise, you'd probably, simple stuff first. You'd look at a full blood examination, wouldn't you? You want to make sure he's not lymphopenic for some sort of, I know it's not classic SCID, but even before you go down the route of fancy pants tests, it'd be nice to know that he's got those things normal as well. I suppose that's what I'm thinking before whatever comes next.
So I did meet him at the point that it was clear that he had a cosmoprotein allergy, and of course that's what we're talking about tonight. But I think it's really important, as both you and Nikhil have done, to kind of make the point that this is not quite normal. And although I had on that slide that he had a normal immune workup, actually the story goes that they went to India, had homeopathic treatment there, had serum-specific IgE testing done to hundreds of things, that they came back when they came to see me, brought these results when they eventually came back to New Zealand when I met them for the first time. To talk about the pages of results, that was what I was met with in terms of pages of results, and including to antibiotics that he'd never been exposed to before. But thankfully, things had just, other than that, he had then developed food allergy, and I'll get onto that in a moment, but these abscesses and this fistula had just self-resolved. And it wasn't as simple as that, because he hadn't actually had a neutrophil oxidative burst done before he left the country. So the first thing that I was concerned about when I met him was chronic granulomatous disease, because I have had patients referred to me with a history of cosmoprotein intolerance, who land up having chronic granulomatous disease. That thankfully wasn't the story. But yeah, I agree with you both that it's really important to be thinking about these other things in these children who present a little bit unusually. So we do have two questions. They're not specific to the case, but before we move on to the allergy history, maybe we should deal with these, considering we were talking about the gut eubiosis and earlier. So from Natasha Lee, would you expect an increase in allergy incidence for COVID babies that have been born during this pandemic? That is a really interesting question. Patricia, what would your take be on that?
Well, remember, I'm not the immunologist here. You know, my obvious reaction would be the immune system is overstimulated. There's lots of immunoglobulins there. Is it busy producing the protective immunoglobulins and won't have the capacity to produce the IgEs that's leading to the allergies? That's the best I can guess at that one.
Yeah. Nikhil, what would your take be on that? I have not given this any thought up to this point. So I don't know.
Well, I mean, you know, I've got a 50-50. I could just say yes.
Yeah.
but you know, I mean, I think we will, you know, and I think it's not just around, I think we're already starting to see some issues, and I have no idea why we're doing this, and it'll be interesting to hear what Rupert has found. But we have seen over the last year or so what seems to be an increase in kids presenting with things like inflammatory bowel disease and kind of other kind of immune mediated things. And it's always difficult to know why, you know, is it a true increase? And I guess we will have to look at that. But I think the fact that they're isolating and not doing the things they would normally do, I suspect will have as much an influence as actual COVID itself, or you know, anything specifically associated with that. So I do think that, you know, I haven't actually had touch wood, a bug for about a year or so. I haven't even had a cold or anything. So I suspect we are going to start to see the consequences of never getting your immune system challenged, because we're living in a protected environment. So I would predict, yes, we are going to start to see a rise.
That would make sense. In which case, extrapolating from that, we likely may see a rise in food allergy or allergy atopy as well. So I'll keep this case going. I'll come back to this interesting young infant. So when he came to me, he was actually 9 months of age. The history was that, leaving aside the perianal abscesses, which just miraculously healed somehow, he had been fully breastfed from birth, had severe eczema from 3 months of age. We all know the story. Had 3 milk reactions. I don't think the mother quite believed it, and as you wouldn't, the first one was pretty mild, cow's milk formula, tried 3 times at 5 months of age, immediate vomiting after 2 sips. Goat's milk formula, tried at 7 months of age, immediate vomiting, and this time rash after 3 sips. And then finally, at 9 months of age, had cow's milk anaphylaxis with generalized urticaria, wheeze, facial swelling after just 2 teaspoons of yogurt. So kind of a standard IgE mediated type reaction that we would see in a young infant. His mother was a bit surprised when I mentioned that was an anaphylaxis episode, because she'd had quite a lot of other things to deal with this young boy, and so that had kind of been the last thing on her mind. Also had been surprised that he had reacted to goat's milk formula. I'll come back to that in a moment. So at this point, egg and peanut had quite a busy time for this family. They'd moved to India, they'd moved back to New Zealand. Egg and peanut had not yet been introduced. So I have a few questions that I would like to put to everyone. So she's working and really struggling to maintain breastfeeding and working at the same time, and would like an alternative. In fact, she actually came to me wanting to fully wean off onto an alternative formula, which is unusual, in that most of the mothers who come to me want to maintain a combination of both. And of course, we would always suggest breast is best, but I really needed to come up with an option for her. It will come as no surprise to many of the dietitians in our audience that this baby reacted to goat's milk formula. Rupert, what would be the options that you would suggest to this mother with this baby who had a history of anaphylaxis to cow's milk?
So I think it's, as you've alluded to, it would be a surprise if goat's milk, or in fact any other mammalian milk, didn't cause a reaction. I think that was destined to fail. I'm not critical of the mother. I think people don't know this, and that's okay. Given it's an anaphylaxis, it's IgE mediated, and it's a severe reaction, you know, I'm going to be recommending an amino acid based formula. I think we can't be certain this child would not have a reaction to even an extensively hydrolyzed feed. So I would, you know, miss that step and go to amino acid based formula. Now, obviously last week when we were talking about non-IgE mediated type of reactions, I'd have had a wholly different answer. But I think this baby, really for safety reasons, the only thing you can be absolutely certain won't cause a reaction would be amino acid based formula, which maybe a 9-month-old baby is not going to love the taste of, but I think that's the only safe approach that I would take for this baby. I wouldn't do EHF, I certainly wouldn't do mammalian milk, and I wouldn't do soy. So, you know, pick any one of the amino acid based formulas that you have available in your country of choice.
Nikhil, it's no IgE mediated allergy question, so I feel a bit mean asking this of you, so feel free to say you would defer to your allergy specialist if you want. But what would your options be?
No, I mean, of course, I would defer to you. But no, I mean, I totally agree with Rupert. I think this is quite it's quite a significant history in this child. It started off with really early onset disease, which we presume is related to the allergy as well. This kind of immune dysregulation, the severe eczema, which we will often see within this group, and now you're getting these immediate reactions. So I think I would totally agree. I would go to an amino acid formula. You don't really have the luxury of kind of waiting to see for months how the kid gets along. So I think I would definitely agree with that. And then I would ask you.
Yeah. Okay. So, I'll just ask if we could have a look at this slide that I have up. So in New Zealand, our criteria are slightly different. They're somewhat similar to in Australia, but slightly different. I completely agree. I would not want this child to have an extensively hydrolyzed formula. With a history of anaphylaxis. If they had IgE-mediated reaction without a history of anaphylaxis, then absolutely happy to try an extensively hydrolyzed formula and possibly trying a little bit in clinic first. We would, over 6 months of age, need to try soy formula first. Having said that, this child is somewhat different. He would meet our criteria if soy was not indicated for an amino acid formula. And what we haven't touched on yet is what would you do, what testing would you do for this baby? And in this situation, I found myself in a situation where this mother was understandably very risk averse, because normally I'd say, well, let's just try some soy formula, and if you want, we can do it in the clinic, or we can bring him in for a little bit of a trial with our nurse. But she wanted to do skin testing first, and he was soy sensitized. And that maybe isn't surprising. He's a boy of Indian ethnicity, or his family have migrated to New Zealand, who already has milk allergy, and he is at risk of multiple food allergies. So it wasn't that surprising. So yes, he went on to an amino acid formula. I guess I'd just like to remind our audience, just before we keep chatting away, to please post more questions. We'd love to answer them or to discuss them, even if we don't have the answers. So my next question would be, And again, this seems a bit mean as an allergy specialist, but would you do testing to cow's milk, firstly? And what would you do testing to any other foods?
So I suppose, look, I think in reality, we had him on the panel last week. I'd have probably, spoken to Sam and said, look, I'm pretty worried about this kid. Can you see them soon? And I'll expect some skin prick tests to be done. Look, sometimes, and I probably did it more in the UK when there was, obviously Nikhil's worked there more recently than me, but it was quite hard sometimes to get an allergist to see a patient. It took a while. And in this sort of kid, I'd often actually do some blood tests. I do some RASTs. And if I was going to do some RASTs on this child, and once again, this may not be evidence-based, but I would probably, as well as cow's milk, them do it to other high-risk allergens, acknowledging that there's not a correlate between the RAST and the food. But if the child was really positive to peanut, an egg as well as milk, I'd probably say wait till you see the allergist before you try any of those high allergen foods. And that would be my approach if there was a delay between me and the allergist seeing it. And I would make it, once again, this is very different in the child who's got a sort of a non-IgE cow's milk allergy we talked about last week, where I'd be encouraging early introduction of all those high allergen foods. I am a bit worried about this boy being multiply sensitized. And in an ideal world, yes, you or Sam would see them the following day and do some skin prick tests. But if there was a delay, I might do some RASTs. And I would certainly not be overly keen on letting the mum, be giving egg and peanuts, at home if she lived in Dunedin or wherever that is relation to you. It's probably a long way away, isn't it?
Tokoroa, maybe. Dunedin would be fine. Because, yeah, Dunedin, we're very good general paediatricians with interest in allergy in Dunedin. But yeah, Dunedin's lovely. So yeah, it's that balance. And I think sometimes it comes down to what an ideal scenario is in terms of a theoretical scenario and that balance of that child in front of you. So if I can just have the next slide shown, and then I can talk you through what our plan was. So I did have a discussion with his parents about how they felt about introducing peanut and egg without prior testing, off the back of some very well-known studies that I'm sure we're all now familiar with, the LEAP study with early introduction of peanut in particular in high-risk infants, the post hoc analysis of the EAT study with multiple food introductions in high-risk infants, and a number of other randomized controlled trial studies showing that we really want to try and get these foods in early alongside breastfeeding in our high-risk infants, even if they already have food allergy. But again, it's a discussion I have with the parents about how comfortable do you feel about doing this? And if they feel comfortable, they can even have peanuts sitting in the waiting room. They did not feel at all comfortable. And so he did have skin prick testing, 8 millimeters to milk, confirmed his milk allergy, 5 millimeters to egg, 4 millimeters to peanut, and 10 millimeters to soy. And hence the advice to avoid all mammalian milks and to introduce an amino acid formula, and a referral was sent to a dietitian. But again, Nikhil, what would, if you were seeing this child before he had, with these results, before he had been referred to see an allergy specialist, is there anything else you might suggest is done, firstly to provide some protection for this child, but secondly in terms of potential next steps to see what those results might mean, or preparing them for what this allergist is going to say that might be kind of completely different to what they're going to be expecting? Because presumably off the back of those results, they're going to be expecting they're going to need to avoid all those foods.
So I guess this is probably not going to fall into an area where I see a lot of children, because by now I probably would have sent them to an allergist to get a better kind of opinion and advice for that. So I'm not sure that I would be very confident in terms of whether they should be given precautions for anaphylaxis, or how much more testing you would need to do for that. So I mean, of course, in a non-IgE
enough.
mediated setting, it's a little bit different,
Yeah.
and you know, we can be a little bit braver around trying things or the advice that we give. But like I said, in this child, it kind of worried me, or it has, you know, the picture kind of worries me from the word go. So I would probably end up, until they actually have a formal opinion, just being a bit more cautious.
And I completely agree with you, and I'm delighted to hear that answer, actually. This child, you know, so he's never met egg. We don't know what he'd be like if he did meet egg. We don't know what sort of reaction he would have. And so, yes, I would want him to avoid egg before seeing me. Again, likewise with soy, he's sensitized, highly sensitized, he's never met soy, or peanut for that matter. And so what we ended up doing was going through sort of a stepwise, under the allergy service, trials of various things. So firstly, a peanut challenge, because he was sensitized to peanut 4 millimeters, but that didn't necessarily mean he was allergic. However, he was allergic. He developed urticaria and vomiting after half a teaspoon. We also then did an egg and bacon challenge, in terms of, we know that a lot of our children who are egg allergic will tolerate, IgE-mediated egg allergic, will tolerate egg in modified form when it's baked at high heat, and it changes it from a conformational epitope to a linear epitope because it's baked at high heat in a matrix. But again, not something I would suggest doing at home for this child who had never had even a crumb of egg in baking. Likewise, we did a milk and baking challenge. Sorry, he tolerated the egg and baking challenge beautifully, and his mother was delighted that she kind of had it in there. Likewise, we did a milk and baking challenge, and but he developed generalized urticaria to that. And soy was deferred until later. However, when we did try it later, it was tolerated a couple of years later. Other things, as I said to the audience, absolutely feel free to continue asking questions. We're very keen to have discussions about those.
Can I ask you a question, Shannon, about because I guess, I mean, for obviously it's completely relevant for our non-IgE dairy ones, but I mean, obviously as a gastroenterologist, I'm familiar with the idea of egg protein, the change when you bake it. But is there the same degree of evidence and certainty around, you know, baked milk as a means of introduction, or is that still a bit less clear cut than baked egg? I'm genuinely interested, because not that I would recommend it without seeing an allergist, but I just mean for my general knowledge. Is baked milk a thing in the same way as baked egg?
Yeah, it absolutely is a thing. However, having said that, we seem to see more tolerance in our egg and baking, for our egg and baking challenges. And we have had some reasonably nasty reactions to milk and baking. And this child with a history of anaphylaxis to milk, I definitely would not be keen to introduce milk and baking at home in this child. But yes, there is good evidence that it's modified as well. And it is a way to potentially slowly get things in.
That's great, thank you.
Can I ask a question? I'm going to kind of direct it to Patricia, actually, because often when we end up in situations like this, it's like, how do we get them out of this situation? And, you know, the kind of reintroduction in the kind of non-IgE, of course, we would use ladders to try and improve their diet. But if we kind of think of this starting off as a kind of dysbiosis, and now we're trying to get this child out of this significant situation, is there any evidence to manipulate? Because obviously the diet would have now started to impact on the microbiota themselves. So is there any dietary manipulation that we can use, or microbiota manipulation we can use to try and help improve how
that's actually what I was immediately thinking of with the story is the history of it. It's a clear case. The antibiotics would have introduced the dysfunction, disturbed the normal microbes, and then the travel also does it. The breastfeeding, while breastfeeding is best, breast milk varies from individual to individual. And as the baby is older, mum's breast milk isn't the same quality in terms of its oligosaccharide and the microbes it carries with it. And the more stressed mum is, the worse the breast milk is. So the poor kid, first of all, has the antibiotics, and then the travel, and mum's stressed, and the more sick the kid gets, the more stressed mum gets. And so that was exactly my thought is, sure, you can address the clinical aspect of it, but how can you fix the other side of it? And there's two ways I would suggest is, one is with the prebiotic concept. That's the oligosaccharides that promote the beneficial microbes, particularly the bifidobacteria. And even in a 9-month-old baby, they still need the bifidobacteria. So supplementation, and there's some commercially available prebiotics that will start to allow the good ones to regrow again. And another concept is the probiotic concept. And there's a lot of, unfortunately, there are a lot of commercial probiotic products available, and not all of them are efficacious. So if I suggest a probiotic, I would say one that has been clinically trialed in young children. And there are products out there. I've been part of studies where we've given probiotics into preterm low weight babies, and health benefits and weight gain and things like that. So probiotics can work, but not all probiotics. So I would, with that child, suggest a probiotic, and definitely an extensive evaluation of which one to use, because I've been part of studies where probiotics in infants from 3 months to 18 months has decreased atopic dermatitis, but that was a particular strain that was evaluated. So yeah, in addition to and the good thing about the prebiotics, the oligosaccharides, they don't induce allergic reactions. So it's not going to be detrimental, and it can help the gut microbes re-establish and rebalance.
That's really interesting. There's a question, more a comment than a question, well, comment and a question from Kevin Sue saying L-plantarum has been used successfully with peanut anaphylaxis. Has not been mentioned subsequently. Is this a worthwhile option? What would your take be on that, Patricia?
There are a couple of
studies.
Confess
I can't answer
that. There are a couple of studies. There's a plantarum and there's a rhamnosus that has been co-administered with peanut allergy to increase sensitivity. So I'm not as familiar with the plantarum study as I am with the rhamnosus study, but that's what I say. Particular probiotic strains can have the double benefit of re-establishing a microbiome which is beneficial and more ideal, and also affect the immune reaction, down-regulate, so that it would have both gut microbiome regulation and down-regulation of the allergic response, and co-administered with small amounts of peanut allergy.
Yeah.
I think that's also been done with cow's milk.
I mean, can I say, look, I think it's one of those things where it's okay for a thing to be logical, but it doesn't necessarily mean that it works. And I think if you look at some of those peanut tolerance inducing studies, where one of the arm had probiotics, it's not abundantly clear. They're not always well-powered studies. This is not the extreme 10mm wheel anaphylaxis that we're trying to induce in. At least I'm not picking on anyone, but, certainly in one of the studies from a hospital very close to where I work, but not the one I work in, they certainly chose the low-hanging fruit of the most likely people who were going to become, tolerant of peanuts. This wasn't all comers with anaphylaxis. So I think, it's like anything. Look, I think you know this much better than me, Patricia, but we've got to interpret some of this literature cautiously, because, what I don't want is people thinking that, they can go home and DIY, induction of tolerance, with a bottle of Yakult and some peanut butter. And I honestly think that, some of the patients I see have literally almost proposed that, even though I'm not looking after their peanut allergy, because of, what they've read in the lay press. So I think it's really important advice for our patients to recognize that this, if it's ever done, it needs to be really carefully supervised. And it's not every child with peanut anaphylaxis who can have tolerance induced with a small amount of peanut and a probiotic. I don't know what, do you get many of those requests, Shannon?
Just about every clinic.
Yes.
And my advice is we're not there yet.
Yeah.
This is still very much in the clinical trial phases. very interesting. And even a follow-up from the probiotic study in the area that you live in, Rupert, showed that with a different of that study repeated, but done in a different way, did not show any benefit.
Agreed.
And yeah, so I do think we do need to be very careful how we interpret this, and that's not ready for clinical practice yet in terms of desensitization. Research, absolutely. Well-controlled environments, yep.
And
I think
careful
that's a
selection.
brilliant summary. Yeah.
Yeah. It's not a DIY yet.
No. Yeah,
absolutely not.
Yeah, completely agree. Completely agree. And without leaving out our audience's questions, is breastfeeding generally better for developing microbiota than formula, Patricia? Is a question from an audience member.
Well, breast milk has all of the oligosaccharides and the microbes in it that the baby needs. And infant formula is trying to replicate that. But breast milk has, I think last count it was hundreds of different types of oligosaccharides, whereas the infant formula, they're supplementing it with a couple. And infant formula now, that you can get it supplemented with human milk oligosaccharides, but it's just a couple. So yeah, breast is best, but if breast isn't available, or if mum is, as I mentioned, the quality of the breast milk varies. So I would definitely also look at mum's health status as to whether the breast milk should be supplemented, not removed and replaced.
Nikhil, any final thoughts on before we have to wind up about this case, or just in general?
I mean, I think this is it's a really interesting area, and I think, you know, a lot of work that we were doing before was just to try and deal with the allergy and get on top of it, whereas now, in terms of trying to maintain the long picture in terms of, because I know there was a lot of things around you know, taste as well, and we see a lot more children who have food aversion now and have difficult diets, and then you introduce allergy into the mix, and then they have even less, and it becomes even more challenging. So I think the whole area is really evolving, and you know, how do we actually help them along, especially if the immune system is changing and the dysbiosis, or what we shouldn't call it, you know, is evolving. So I think it's a really exciting area that we continue to focus on as time goes on.
And Rupert?
No, I think it's been really good to have the balance of allergy, gastroenterology, and science today. I think it's been a great talk, but I think it is the case that this is a journey that we're taking, but we're not there yet. And I think it's important I think to remind everyone that it's an exciting journey we're part of, but we're nowhere close really to being able to answer things. Nothing is as simple as a simple probiotic, you know, changing everything, you know. And I think I made this point last time. It's pretty obvious that if you have probiotic X and you look in a baby's stool while they're on the probiotic, it's all going to be there. The real question is about sustainability of changes to gut flora, isn't it? Can we do something that leaves a legacy beyond the time they're on it, or do they just go back to where they were? You know, that's the question for me, I think, in terms of dysbiosis. Can we keep it as it should be, rather than just temporarily fixing it?
Well, I have to say, I have learned so much from the three of you tonight. Thank you so much. From maybe not so simple allergy case, but still, you know, relatively simple. And I've really appreciated your insights. And it's fantastic to co-chair again with you, Rupert. And thank you so much, Nikhil and Patricia, for joining us tonight. Thank you to the audience for attending and for posting questions. If there are any that we didn't get to, I apologize, and hopefully we can get to them next time at the next Podinar, which is on the 20th of November, I believe. So I look forward to seeing some familiar faces then, and our audience members, and thank you for joining us again tonight. Have a good
Thanks,
evening.
Shannon.
Thank you.